I'll just switch it off.
Okay, lovely to see you, Stephen. Okay, I will mute everyone, so it just makes life easier. So, any new declarations of qualification for office or declarations of interest from members of the Council of Governors? Could you raise a digital hand for me, please? Okay, despite everything going on, I can't see any hands raised, so that's good to know. So we'll move on then to the minutes of the meeting held on the 18th of September. The Council of Governor colleagues, if there are any points of accuracy which you would like amended, could you raise a digital hand for me, please? Again, I can't see any digital hands raised, so I'll take those as an accurate record. So we'll move on then to the matters arising in action update, which is on page 16 of the pack. And the first was a briefing on the community integrator service to be delivered at the September meeting. A written update was circulated. That's correct, Adam, yes?
That's correct, Joe, yes.
Thank you. And we will no doubt be coming back to that as we continue on our desire to be an integrated healthcare organisation. The next action in progress was an update on stroke services. And again, Adam, we've been talking to the ICB on that. Do you just want to give a quick update, please?
Yes, I do. So we had our provider review meeting with the ICB a number of weeks ago, and this was one of the agenda items. We specifically raised the issue of challenges with the stroke pathway in terms of Swift and George Eliot, indeed, having to conduct the diagnostics before patients were then transferred to UHCW. And we talked about some of the pathway challenges which were happening outside of the model that has been agreed for stroke services in Warwickshire. The ICB agreed to pick that up, share a bit more information from the review that has been previously done, but also look at the data that we're holding as a trust for number of suspected stroke cases that are being held in our emergency departments and having diagnostics done locally. So we're providing them with that data, and then they will agree on the next step. So I will update a future COG on where that has gone.
Okay, thank you very much, Adam. And then the final update was the Salix project update. And there's obviously an awful lot of work that we're doing, Adam, in terms of the green agenda and driving to net zero. We're one of the leading trusts in the country on it. So if we can circulate that early in the new year, that would be super. Thank you. Are there any matters arising that colleagues feel I've missed? If you could raise a digital hand for me, that would be helpful. Okay, so I can't see any hands raised, so I'll take that as all of the matters arising being covered. Just in terms of some things that are happening generally, the Trust is incredibly busy at the moment, as evidenced by just a couple of weeks ago on a Monday. We had our highest ever recorded visits to our A&D department, with 393 patients arriving into our A&D. I would like to just comment a couple of things on that. The first is my enormous thanks to our frontline staff who are coping with quite extraordinary levels of demand coming into our A&D in particular. Demand into our A&D has grown by over 35% in the last 4 and a bit years. To put that into some comparison, over at UHCW, their A&D demand has dropped by about 5%. So we are incredibly busy. And the A&D department, as I assume all of us on the call have visited at some point at Warwick, was never designed for that level of volume of traffic. And so at the board meeting last week, we did sign off a incremental level of investment into the A&D. But certainly if that level of demand continues, and when you see the increase in housing development around South Warwickshire, there will be a need for us to look at quite radical solutions in terms of helping people avoid coming to the A&D in the first place, but looking at the configuration of the A&D to make it safe for the next 5 to 10 years. And the third point to make is it does make our financial position even more challenged. Ravi will no doubt be covering under the financial assurance report where we are financially, but it's worthwhile remembering that almost uniquely, Coventry and Warwickshire has not rebased its UEC and maternity block contracts to the acutes in Coventry and Warwickshire. Normally what happens with a block contract is at the end of every year, there's a rebasing for what has actually happened. In Coventry and Warwickshire, for reasons best known to the previous ICB team, they didn't rebase the contract. If they had have done, we would be receiving £30 million more income a year. And you can just imagine what we've been able to do with that in terms of investment. So we're incredibly busy, enormous thanks to the team. In terms of our ICB, they are now in a clustered arrangement with the Hereford and Worcester ICB. I think that's good news. We have a new chair of the ICB, Krishni Waring, who I'm very impressed by, having worked with her in Hereford and Worcestershire in my other chair responsibilities, and a new ICB chief executive in Simon Trickett. And at some point, I think it would be great to have them at one of our Council of Governors meeting. Simon is a very talented chap as well. So I am more optimistic about the ICBs going forward. The third thing to brief you on is the developments generally which are going on in the NHS. You'll have heard of the 10-year plan with its 3 big shifts, moving more care into the community and out of the acutes, moving from analogue into digital, and moving more effort and money into prevention. Those 3 big shifts relate very clearly and closely to the strategy that Swift has been engaged in for the last 10 years. So I think all of that is good news. I do still worry, though, that we need to be quite ruthless in our prioritisation of what the acutes are able to do, and that the acute hospital sector should be seen as just an acute episode visit rather than somewhere where people spend too much time in or unnecessarily visit. And the 3 key priorities which I discuss often with the board from my perspective is firstly to bring life safely into the world and to make sure we have excellent maternity services. And I can again assure members of the public, as the NED safety champion with Dr. David Spraggart, that our maternity services are very good at Swift, albeit, like the UEC, extremely busy. The second is to help life leave the world with dignity. For those of you who joined us at the AGM, Kate Hodder gave a very good presentation on our palliative care services, which we are continuously proud of. And in terms of allowing life to leave the world with dignity, we work closely with our strategic partners in the hospice area and our community teams. And the third is when you have a medical emergency, and I include cancer in this, that we continue to provide the levels of quick turnaround and service that you would hope for in your moment of immense need. I do worry about our cancer services, as I said, that we rely on UHCW for our oncologists, and so we're working very closely with them to try and improve that. So we've got the 3 big shifts in the 10-year plan, which we're aligned with, and we've got our 3 key areas of focus going forwards, which we continue to ensure that they get our due attention. We have our EPR programme ongoing. That is an area of risk for us because any change to the electronic patient record is not a trivial change. And Adam and I are staying close to that, Adam in particular, We have a briefing later from Robin Sneed, our new digital director, who's ensuring that from an executive side that work is progressing. But that is still, I think, the biggest area of risk we have over the next couple of years. That's all I intended to say, to be honest. Are there any questions from governors on what I've just said? Okay, I can't see any hands raised. I'm having a bit of a technical problem at my end, but I think the next thing for us to move on to then are the assurance items. And the first is the governor requested assurance. And lo and behold, it's how the trust is ensuring the new EPR works. So Adam, over to you.
Thanks very much. As Russell has touched on, the EPR is clearly one of the biggest projects we've got. It's risky, it's hard to do. You'll have seen high-profile stories about the challenges with EPR programs across the NHS in the past, but it is also one of our biggest opportunities for transformation, for productivity, for modernising the way we provide care. So is despite all the risks, a really exciting piece of work. I think we've got Robin and Sarah Mills here to talk in detail about where we're at and the work we're doing to ensure we're getting what we need. So Robin, over to you.
Thank you. Thanks, Adam, and thank you for the invite to this forum. I think that the key thing with the EPR is that we see it very much as a clinical transformation of how we work with across the acute organisations. This is not an IT program. It is changing the way effectively our clinicians work, the way that pathways work for our patients. So it is fundamental that we have strong clinician buy-in to the way in which the system is developed and the way in which it's implemented. And that is the approach we're taking. We've got strong leadership teams with it. We've got strong clinical leaders, nursing leaders, and leaders across each of the areas and professional areas within the organisation. And we continue to work closely with all of those individuals. As Sarah will come on to in a second, there's many critical stages of the program. We're at the stage at the moment where we are collecting data from our teams on how our patient flows work, how our clinicians work, and they will feed into effectively the initial build of the system that then we will trial, and we will work with our teams to get them familiar on that system as we move forward between now and go live. So on that note, I'll hand over to Sarah to give more detail.
Thank you, Robin. Good afternoon, everyone. I'm Sarah Mills. I'm the EPR programme lead. So I'm part of the team that is delivering the EPR on behalf of Swift and George Eliot, because this is a collaborative implementation that both trusts are on the same programme at the moment and running to the same timeline as well. So we are doing the same activities that I will talk you through today in parallel with colleagues at George Eliot as well. I've got a few slides which I will just share because they will help just to talk through the activities that are ongoing at the moment. Can you see those?
I can't at the moment.
No, let me try again. There we go.
Yes, I can.
You can see those now. Fabulous. Okay, so I'll do a little run through of the programme activities that have already taken place, just to give you a flavour of all of the effort that has been put into getting us to, I think we're around about the 6-month mark now since the programme kicked off. So the first activity after the programme was formally approved to proceed to implementation was in May, and that was our programme kick-off. So that was our official start of the programme and the EPR journey. And that was an in-person event with the whole of the wider EPR programme team. So I've mentioned already that Swift and George Eliot are both on this EPR implementation journey together. UHCW are also an important stakeholder. They are already live with the EPR. So what they are currently using is what we will be joining them on when we go live next year. So their experience and their knowledge of the EPR is really important to our programme, and that's key to making sure that we get an EPR that works for all trusts, is to make sure that we're working collaboratively with UHCW throughout this process. Innovate, who I'm employed by, are very close to both trusts. So we were a key part of that programme kickoff as well, as were Oracle Health, our EPR supplier, and SCC, who help us manage the contract. So that event was really important to set the scene for everybody who is going to be hands-on with the implementation, so that we all understood the timeline, we understood the activities that would be taking place at every stage in the programme, and so that we all understood our individual responsibilities as well. But probably the most important thing from that event was bringing everybody together as a team, so that we start to build on those relationships that need to be really strong and really work effectively, because this is a long programme, and we have all got to work together and pull in the same direction. So that event was really incredibly helpful for making sure that we got off on the right foot and that we work effectively together. Soon after the kickoff, we developed as a wider team a programme vision and guiding principles, which we are using in all elements of the programme implementation. And I'm very happy to share a copy of those afterwards if that would be of interest to anyone. So the vision sets out some really key themes that we need to use to underpin all of our activities. And I think Robin, Adam and Russell have all touched on several of them already. So key to all of this is that the EPR is clinically led, and that what we deliver is safe and effective, and that it supports the best possible care for all of our patients, and that it is a collaborative effort. So within every organisation, but also across all the organisations that form the programme team, we have to collaborate to make sure the implementation is as effective as possible. So all the decision making and all the activities that we have undertaken and that we will continue to undertake are guided by that vision and those principles that we set out at the outset. The next piece of activity was our current state review. So that happened between the end of May and the beginning of July. And there was a 3-week block of current state review activity for Swift, and then a 3-week block of the same activity for George Eliot. And this was a series of workshops. So there were multiple workshops every day over those 2-3-week blocks, where members of the programme team and members of the trust teams came together in small groups to discuss how each service and each department currently works. So as a programme, we split the programme, because it is so large, into work streams, and each work stream has a specific area of focus. So we have at this point in time about 30 work streams, and I won't talk through all of them in detail, but for example, there is a work stream that is focused on ED. There is another work stream that is focused on theatres. So all the workshops that happened in the current state review period of the programme were focused on their particular subject area, and bringing in members of the trust teams to talk through how they currently work. So what does a day-to-day or a normal day in the life of that department work? How do they capture the information about the patients that they see? What's on paper currently, what's already in an electronic system that the EPR will replace, or what's in an electronic system that will continue to work and that will need to integrate with the EPR. So those current state reviews were really, really important for us to capture how the trusts are currently working, so that we can then understand what needs to change when the EPR is implemented. So that has really guided all of the activities since then. After that, we did a series of events across a week at UHCW, and this was Future State Review. So I mentioned earlier that UHCW is already live with the EPR. They've been live since the middle of last year, so it is embedded now, and it is their normal way of working. So Future State Review is looking at what does the system look like? What is it going to be like? How do the processes work? So UHCW members of staff, clinicians primarily, delivered another series of workshops, again to our programme team and colleagues across both trusts, to show how they use the EPR, how have they built it, and how does it work for them? And that then informed our next stage of the programme, which we're just coming to the end of now, which is our design phase. So localisation or design is, it's been a 13-week period of the programme where, again, we've had work streams coming together to discuss their particular area, and to look at how the system is currently built for UHCW, and to think about and decide what changes need to be made. So how do we make it work for the way that our trusts need it to? And all of that is feeding into the build that Robin talked about. So that's the next stage that is happening at the moment and will continue for another couple of weeks, is taking all of that information that we've gathered during the design phase and building the system to the way that we need it to work. So that's everything that we've done. I'll move on to what's coming up. So the next key activity in the programme timeline is future state validation, and that's scheduled for the week of the 4th of December. And again, it's a very collaborative exercise. So workshops again, where we are inviting anyone in the trust who would like to sign up to come along and see a patient journey in the morning. So it walks through how the EPR system has been configured for us, step by step, what that would look like for a patient journey on a particular pathway through a certain part of the trust. And then in the afternoon of each day during that week in December, we will have breakout sessions that will be more detailed in each of those workstream areas. So we will have a team of people led by a clinical member of staff from the trust, who again is walking through a more detailed demonstration of some specific workflows within the EPR. So that should start to give a wider sense to the trust of what's coming, what it looks like, how it works, and to really showcase all of the efforts from everybody that have been made so far since the programme kicked off. We then, in the new year, in the very early new year, enter into a stage of quite intense activity within the programme, lots of things happening alongside each other. So the work we've been doing so far has been very sequential. We've done the current state review, completed that, and then we've gone on to future state review. The activity from next year, once the system has been built, we start to do lots of things alongside each other to make sure that we're in a good position for going live as planned in October. So lots of these things that you're seeing on the screen at the moment, the testing and the loading of the data, the trial loads and the maintenance training, those activities are all happening at the same time, because that's how we need it to happen, to make sure that we can bring things in within the timeline. So system testing is exactly as it sounds. It's blocks of activity where we've got experts within our teams who are at the moment furiously writing scripts that will give people all the steps they need to do to test the system. And then we will have an intensive block of 5 weeks that starts in January of those scripts being performed within the current built version of the EPR. So that's really to highlight to us any problems, anything that hasn't quite been built right or something that doesn't work. This is for us to make sure that we pick those issues up and we fix them, we test them again, and we make sure that the system that we go live with is in the best possible state at the point that we start using it. Integration testing is a technical piece of work that happens sort of in the background to make sure that all of those other electronic systems that I talked about that are not being replaced by the EPR but are really important for gathering information about all of our patients, that those work and can feed information into the EPR, and also that the EPR can feed information into those other systems. So the integration testing is really making sure that the whole landscape of electronic systems that we have within the trusts are going to work and work effectively with the EPR when it launches. The trial loads are about making sure that all the data that we've got in the systems we're using at the moment, but that those systems that will be replaced by the EPR, that we can effectively transfer that data into the EPR at the point just before we go live, so that we've got all of the information that we need about our patients from day one of the EPR. We need to make sure that we've tested that really thoroughly, that the data transfers completely, and that it transfers accurately as well. So again, a lot of activity with a lot of teams behind it who will be doing that testing and repeating the testing to make sure that when we do transfer the data, which happens in the few days leading up to go live, that we've done that and we've tested it and we can be sure that it is as complete and as accurate as we need it to be. And then the last thing on there is maintenance training. And actually in the course of this week, we've had a preliminary meeting to start the handover process. So because the system is now well on the way to being built to our own specification, there will come a point again in the early new year where Oracle Health, the supplier, hand over the remaining build of the system to our own teams. So there are lots of discussions going on at the moment to make sure that we've got teams who are trained and are ready to take on that responsibility. And part of the reason for doing it at this point in the programme is so that we've got time before the EPR goes live to do any remaining configuration that hasn't been captured in the early stage, but that arises over the course of the remainder of the implementation stage, and that our teams can sort of practice while we've still got the full support of Oracle Health, and so that they can be ready when the system launches to take on that full responsibility of all of the configuration and maintenance that will be needed once the system is live. So that's what's coming up, and that will take us through almost all the way to go live. This is just a very high level view of the programme timeline. So you can see where we are at the moment at the end of the sort of the data collection and design phase. And just about to go into future state validation. And then all of those other activities that I've just mentioned are sort of in that period from now onwards, leading up to go live in October. We'll obviously have a really intensive period of training, and we are talking already about how we make that as effective as possible so that all of our staff are ready and feel comfortable and confident to use the EPR, because it is a big change and we recognise that, and we're doing a lot of work to make sure that everyone is ready for that change. So there will be lots of different methods of training people depending on what their preferences are, and we will try and be as adaptable as possible and as flexible as possible so that if people want to come back and repeat their training, they can absolutely do that, and so that there are ways of them practicing as much as possible and being ready. And we've started to do some of that work, setting up some test labs so that there are versions of the hardware that people will use, so computers on wheels or tablet PCs, so that members of staff can come along when they've got some time, and a member of the EPR programme team can guide them through, and they can sort of get a feel for some of the equipment that they will be using as well, where it might be different from what's being used at the moment. And then immediately before go live, we do a full dress rehearsal to make sure that everything that we've built and everything that we've tested is as we expect it to be. And it also takes us through, the dress rehearsal will be a replica of what the go live period will look like. So for everybody in the programme team as well, it will be a chance for us to practice, make sure we understand the order of events, and also to pick up anything that we might need to refine, or any processes that we might not have quite got right. And then go live is planned for October. So at this point in time, we are on track for that. It's been mentioned already, it is a big programme. There are a lot of risks. We are managing those risks, and we're escalating those risks for support where we need to. And I think at that point, I will perhaps pause. I've lost track completely of how long I've been talking for, so I'll stop there. If there's anything that Robin or Adam would like to add in, and also if there are any questions, I'm very happy to take them.
That's great, Sarah. Thank you. Robin, Adam, is there anything you'd like to conclude with?
No, nothing from me, Russell. Thank you.
Okay. Like I said, if we need to move on, if colleagues can pop questions into the chat box. Tim has asked the absolutely key question about protected time to engage and learn the system for clinicians. Yes, we are doing that, Tim. As ever, the challenge is to make sure the clinicians actually take the protected time and do the learning in preparation, because that's where it can also often go wrong. So I'll invite one question from Mike, and then if other governor colleagues want to ask questions, please pop them into the chat box, as Callie has done. Mike.
I was just typing it. I got halfway through, but being a bit of an anorak, I'm very excited by all of this. I think it's looking good. I think it looks to be under control. I've been talking to David Fitzpatrick, our governor expert on these matters. He's not with us today, but he'd want me to ask this particular question, which is about the change control mechanism. which he gets the sense is a bit difficult because UHCW have to sign everything off. So in terms of tailoring the system to make it work for us, if UHCW don't like a change we want, then we've got a problem. So is that a risk for us? Simple question, but I'll take an answer in writing if you like.
Okay, Robin.
Yeah, it's a really valid question. We've got a single instance forum, or a couple of forums with UHCW, where us with members from George Eliot, Swift and UHCW sit together, and we talk through changes as part of the governance structure that particularly monitors change control. And we're working well with UHCW, and inevitably there will be some areas of contention, but we'll work through those together. And we haven't yet come across any specific areas to note, but again, as you say, there are always risks, but we will manage those on an individual basis.
Thanks very much, Robin.
Sarah, your hand went up. Was there anything you wanted to add?
Robin took the words out of my mouth.
Okay. Like a good colleague often does. I think the key thing, Mike, is what we don't want is too much localization of the way the system works, so that for the people of Coventry and Warwickshire, it feels all very seamless. So I think that's the key thing, and we just need adults in the room when it comes to that joint decision making and sign-off process, that we end up with the right conclusions. But Governor colleagues, please do carry on popping things into the chat box as you desire. Sarah, Robin, thank you very much. We'll move on then to the operational assurance, the quarterly status update report for Q2. Adam?
Yes, thank you, Chair. I'm going to be relatively brief with this because we did spend a bit of time on it in the round table. The report, though, that you've got in the pack summarises all of our objectives for this year and our progress against them, including a RAG rating of that progress. Clearly, we're only halfway through the year, so they're not all things that are completed yet. In fact, some of them we haven't even started yet. The fit out of the new short stay wards is an example of that. That starts in January. In terms of the report itself, there are only 2 ambers at the current time, and these are areas where we have particular challenges or particular risks. One of them we just talked about in detail, which is the electronic patient record system. And Sarah and Robin have obviously talked about the plan, but as I mentioned, there are risks to that programme. It's a very large programme. It's a very large organisational change. And so challenges clearly follow. And so at the moment, we're rating that one as amber because of the risks involved. The other point on here that's amber is the volunteering strategy. The reason that's amber is a resourcing issue. We do really well with volunteering. In fact, volunteering has really developed over the last few years. We've got over 600 volunteers in the trust. They've provided last year about 30,000 hours, over 30,000 hours, I think, of support to our patients and our staff, which is excellent. Where we have some particular challenges is in the coordination of the resources. We'd like to do more, but we're limited with our resource currently. We think what would help that is by sharing some of that coordination potential with George Eliot. So that's the work that's going on now, a bit behind plan though, and a bit behind resource. So currently being rated as amber, but I am confident we can pick up and deliver some of that by working together in future. I won't go through any of the other points. There's a lot of detail there, obviously, but I'm very happy to take any questions.
Okay, great. Thank you, Adam. Any questions or perspectives to Adam on the operational quarterly status update report? Okay, thank you, Adam. We'll be touching on the finances in a minute, but in terms of clinical governance, David Spraggart, how are you feeling as chair of our Quality and Assurance Committee?
I'm feeling relatively confident that our standards are as good as they've been for some years, and particularly pleased. I mean, I visited the ED department yesterday morning, and I was really pleased how they've actually they've embraced every concern that CQC raised when they visited, and they've almost been enthusiastically addressed them all. And I think that the mood in the department was so much more positive than the last time I went deep, which was only a month before. So I think overall I'm fairly positive. The report that I've sent here, I'm quite happy for people to ask questions on, but essentially it's as read.
Okay, David has kindly taken up the responsibility of, and I've set up across the foundation group, if safety champions for the ED departments. I think the foundation group is pretty unique in having safety champions for the ED departments. So
I think that's true.
Yeah, David's kindly taken up that responsibility. Questions and perspectives to David. Callie?
Yes, thanks, Russell. My question is, all right, you identified significant challenges in specialist palliative care service. Can you tell us a couple of them, how many challenges, how they're being addressed? Obviously, there are other partners involved, but...
There are a lot of partners involved. I think that we should be assured, because Fiona has now taken leadership of a group that's looking at the whole aspect of end-of-life care. Very specialised palliative care. One of the issues are that one is it's specialised, and some of the people, the experts, are few and far between. But also, it's an extremely high-stress working environment. And it's stressful enough being involved in one end-of-life care episode. When it's your daily work and you're dealing with it multiple times, all ages, it's hardly surprising that many of the staff, and I'm pleasantly surprised how many of the staff cope with this, because it actually is a really awkward situation. So I think we should be assured, because Fiona has particular skills in this at drawing these things together, and I think that things will be as much as they can be, but we have to really recognise that the resources that we perhaps need don't exist, or it's such rare commodity, it's going to be difficult to address it.
Thank you.
I think that is one of the, going back to the things which needs more clarification in terms of the 10-year plan, is the whole issue of palliative care and allowing them to leave with dignity, and making sure the staff is right.
To clarify a bit further, of course, it's the specialist end. Most of palliative care is dealt with by community teams, general practice. We're talking here about the very specialised end, which is very high stress.
Yeah, thank you, David. Any other questions to David? Okay, well, this year is probably our most challenged year financially, given some of the issues I was touching on earlier about the block arrangements in Coventry and Warwickshire. Ravi, I can't thank you enough for stepping in to be the interim Chief Finance Officer for Swift and George Eliot. But how are you seeing things, Ravi, on the financial side?
Thank you, Russell. As you've said, this year is probably our most challenging year financially. That said, at month 6, we reported a 1.6 million deficit against the 1.6 million deficit plan. However, the position really has only been achieved by release of non-recurrent deferred income. And as we've already discussed, Russell and Adam have pointed out, the main drivers contributing, I think, to our underlying financial position are the continued operational pressures and the unprecedented demand that we are seeing with record levels of ED attendances. And as Russell has already described, the current financial framework, we do not receive any additional income for the work that we do, either in front door UEC or maternity services. So they're all very much a block contract. And we know that if we were in a regime where we were actually funded correctly, we were paid for that activity, it would mean a substantial amount of income to the trust, so additional income that we could then invest in our services. So for this financial year, to try and mitigate that underlying deficit, we've now set up a financial recovery programme and an internal financial recovery board. And as a result, we've got an accelerated number of CIP schemes that we're trying to deliver to ensure that we achieve our financial position this year.
Yeah, I think it's probably worth saying, Ravi, on behalf of the board, our enormous thanks to each of the divisions for the way they've approached these financial challenges that we have and have really grasped the second half challenge. Any questions or perspectives to Ravi? So Ravi, I know you're not a betting lady, but if you were a betting lady, what would the odds you'd be offering us, or the percentage probability of us being able to break even this year?
I think it's really difficult to say, Russell, at this stage. We've just done month 7, and although the run rate was slightly improved, we are heading into winter. I am hoping that if we are able to deliver all of the activities we have identified, then yeah, absolutely, we should get there. But it is about it, you know, really making sure we deliver on those, and that includes things like increased elective work compared to last year, which going into a winter period can be quite challenging. So little bit early for me to say. There are lots of opportunities, but there are also some risks.
There speaks a person who really rarely puts money down on a horse. Very wise words. Thank you, Ravi. Any other questions to Ravi? Okay, well, we have apologies for Fiona Burton today, and so I'm very pleased that Ellie Ward's with us. And Ellie, the patient experience report for Q1, what would you like to pull out of these?
Thank you, Russell. So you've mentioned the 10-year plan, and of course, patient experience and feedback from our service users is key to that, and improvements off the back of feedback. So although we're still waiting a bit of a steer on how that's going to be managed centrally, we are endeavouring to get feedback in all its forms from anybody who uses our services, and we really support and encourage that, whether it's good or bad. So as you can see from the report, we do try to pull out learning and improvements from feedback we've received and incidents we've been notified of. We are endeavouring to work harder with our FFT provider, who is now very focused on our accounts, and in fact managed to double our response rate in the last month. So that's good, but obviously we need better. There's a most excellent report by our governor on our patient experience group, so I don't want to steal her thunder, but she's put some really good detailed updates on some of the work we've been doing in there. And just some of the themes, Russell, are they're around the things we touched on in terms of our pressures and our capacity. So it's about waiting times, it's about waiting for results and waiting lists, and waiting in our ED is something that we're seeing. What is quite pleasing, and I'm sorry I'm going to steal a bit of thunder here, is that with our cancer report, we actually benchmark very highly against other organisations in the standard of care our patients are receiving, and they've given us extremely positive feedback about the care they receive at Warwick.
Thank you, Ellie. That's great. But we are, I think, as a board, very cognizant that the wait times that some patients are experiencing in our ED department are far higher than they would have known a few years ago. But as I tried to contextualise earlier, the level of increased demand into our ED means, despite our best efforts and an awful lot of investment, we're struggling to provide those turnaround times. But the level of dignity and civility with which we approach every patient, I think, is extremely commendable. So please pass on our thanks to all of the frontline teams, Ellie. Any questions or perspectives to Ellie? Okay, thank you, Ellie. So I'll keep us moving then, and we're on to the audit assurance report, including the audit committee annual report for last year. Robert White, please.
Thank you, Chair. Just a couple things to flag up, and you can see them there in the summary table. So we had a very good, robust annual letter from our external auditor, Deloitte, and so the committee will be taking those recommendations through next month to ensure that there's proper follow-up. And also, and I think to a certain extent on the internal audit recommendations, the head of internal audit was at pains to point out that because of the nature of the trust, people are very ambitious in how quickly they think they can respond to reports, and I think that's reflected in sometimes in us being a little slow on that. So we need a balance of getting better at getting those responses in time, but also setting realistic dates. As you referred to, the report is appended with our Audit Committee annual report. It sets out our responsibilities and how we've exercised those across the 10 areas in the terms of reference. But other than that, and that the audit was slightly delayed, so we're glad that the teams have got together post-audit to look at how we could do that better. Nothing else to highlight, Chair. Happy to take questions.
Thank you, Robert. So overall, in terms of financial control, as Chair of Audit Committee, you're assured of our situation.
Yeah, we're satisfied that there is a robust program of testing our controls and the effectiveness of those controls.
Super, thank you. Questions or perspectives to Robert? Can't see any hands raised. Ravi, could I ask you to take back to all of the financial team, the Council of Governors, thanks for their work, because the question about Robert's assurance on our financial controls is because of the work they're doing and the protocols they're following. So if you can thank them on our behalf, I'd be grateful. We'll move on then to some reports from governors' representatives on projects and groups. The first is the Elective Hub project board. I think since the last Council of Governors meeting, we've actually opened up the new reception area with a new Costa, new restaurant, new M&S. So lots of exciting work going on generally in terms of building. I'll take David Fitzpatrick's report as read in his absence. Any questions or perspectives on the Elective Hub update? Again, I can't see any digital hands raised, so I'll go on to the Ellen Badger Hospital Site Redevelopment Group. Long title for the work going on down there. Mike Wells, welcome back from Japan. Hope you had a lovely trip, and we'll be congratulating you later. But in terms of the Ellen Badger, anything you'd like to add to your report?
Yeah, we had a project board yesterday, so there is some hot off the press news. The medical unit, which I referenced in the report, did open to plan last Wednesday and had 2 patients testing the system out, who were very, very happy. Increasing numbers of people going through it every day, expecting by the end of the month to have people going through it every day of the week, so working days. Lots of positive feedback, particularly the obvious ones of great to be doing it locally, saving time, saving money on travel. Back in the new building, there are now clinical sessions in there every single working day of the week. They started very much in the middle of the week and have now spread out, so there's activities going on every day. And we're just awaiting the final planning permission to be approved before the contracts can be signed with the medical centre and Shipston Home Nursing.
Super. Awful lot going on down in Shipston. Any questions or perspectives to Mike? Okay, thank you, Mike. And thank you to everyone who supported that work and led the redevelopment. We'll move on then to End of Life Care Committee. We've talked about end of life a few times today. I don't think, Michael Coker, there's anything to report on that committee.
No, unfortunately, the last meeting, which I hope to report on today, was postponed, but hopefully we'll be meeting shortly. In fact, I have the date somewhere, and I hope next time to be able to report how the progress has been made on the previous meeting, which, if you recall, was the committee looking at itself to see how much it could improve and what could be done better, which I found, as the outsider, if you like, very, very good, because they were prepared to criticise themselves, obviously constructively, which is something one is very pleased that professionals are prepared to do it.
No, absolutely well said, Michael. Thank you. Adam, could I just ask you to take away that the End of Life Care Committee does seem to get cancelled on occasion. Can we just try and make sure we minimise the incidence of that? Any questions on end of life care from colleagues? Okay, I can't see any digital hands raised, so I'll move on to the Falls Prevention Steering Group. David G, I know you've been unwell and have been a user of our facilities. Like I said in the early pre-meet session, I hope you're feeling better. But David, anything you'd like to brief us on this?
The last meeting was 2 days ago, so only a verbal report. Basically, it's going on as in previous months. The number of falls with harm is increasing, but the number of falls overall is relatively steady. So they put this down to the number of patients being treated in the community. So proportionately, they're not getting so many in. Most of them are more serious now. So otherwise, the picture is quite steady.
Okay, thank you, David. Ellie, is there any worrying trends in your view on falls?
I think, as David explained, it is about the harm levels rather than the numbers of falls now. And we do seem to be seeing an increase in frailty and in bone fragility, these falls resulting in fractures. So it is all those messages about deconditioning and bone health and looking at what we're doing with that, I think.
Yeah. And just, I think, a couple of general observations before I invite questions. The evidence for a hospital-acquired functional decline is really very stark the older you get. So some families who might be listening to the call may think that mum or dad staying in the acute for longer is actually good for their health and well-being. Once the acute episode is over, being up and about is by far the best thing to do. The second is the importance of prevention when it comes to using a walking stick, which I know from my own experience and from loved ones' experience is often seen as an unacceptable sign of getting old. I would just counsel members of the public, for me it's a sensible sign of avoiding falling over if you're at any risk of falling over. So don't ever be embarrassed to have a walking stick when you're going around to prevent a fall. And the third is just in terms of trying to keep physical exercise up. There are some lovely videos you can get on YouTube and elsewhere in terms of strengthening yourself, even if you're sitting down most of the day. And I'd really encourage, again, members of the public who are getting a little bit older to keep themselves moving, to keep their muscular strength up, which again will lead to fewer falls. Any questions or perspectives on falls prevention? Okay, we'll move on then to the Health and Wellbeing Hub Steering Committee. Carolyn?
Yes, the meeting this week was stood down due to winter pressure, CQC issues and chair interviews. The next one is in February.
Okay, thank you, Carolyn. Keep us briefed on that. Mike will be briefing the confidential session of the Council of Governors on the chair replacement programme. Again, just for members of the public joining today, I have to stand down as chair at the end of March, but Mike Flaxman and the nomination committee are running a process to find my replacement. The Medication Safety and Optimisation Committee. Tim, anything you want to brief us on that, please?
Yes, just a couple of brief points on that. So last meeting was on Monday. October showed a slight increase in medication safety incidents. Not surprisingly, the theme is that most of the medication safety incidents occur in the A&E or emergency departments, which clearly reflects probably the pressure that Russell was describing those departments have been having. And as a response to that, we heard that there is a business case in the offing to possibly provide full-time 7-day-a-week pharmacy support within the A&E department, which hopefully will be able to help the hard-pressed team reduce these numbers. It's regarding devices, things are pretty much fine.
Okay, super. Thank you, Tim. Any questions or perspectives to Tim? Thank you, Tim, and thank you for your work in that area. The patient experience group, Holly.
Good afternoon. I hope you can hear me. I just wanted to bring your attention to some of the wonderful things that are occurring across many of the divisions within the organisation, if you haven't had a chance to read it, particularly within out of hospital, emergency and on Farry's ward. There's just, and in response to patient experience and the feedback that we're getting, they just do so much good work. And if you have the opportunity to read it, it'd be wonderful. And the other thing that I really wanted to bring everyone's attention to is the input of Healthwatch for patient feedback and patient experience. One of the things that they've been working on most recently is an engagement piece of work with the communities across Coventry and Warwickshire around pelvic health terminology for the development of a preventative website that can help women and birthing people to understand their pelvic health and prevent pelvic health issues in their pregnancy and postnatally. And without them, that website wouldn't be as accessible and wouldn't have the language that women and birthing people would understand. I think it's a really brilliant report to read if you have a moment to have a look at it. Thank you.
Thank you, Holly. Any questions or perspectives to Holly on patient experience? Okay, thank you, Holly. And then Tim, we're back with you on Quality and Safety Board, formerly the Patient Safety Surveillance Committee. Tim?
Yeah, thanks, Russell. Just a couple of points to highlight on that. The Quality and Safety Board is now joint, obviously, with George Eliot, which is a new change. There are some challenges with that because George Eliot at present have a slightly different system for recording significant events. But the aim is to try and keep shared learning across the two organisations. The two other things that just of note, there is an issue regarding communications with UHCW neurosurgery, which appears to be ongoing, and that was discussed. And we have a number of action trackers which are recording significant events which have occurred within the trust, which obviously they're events that have not come into the formal complaint sphere or the PALS sphere, but remain significant events. The data is accurate with those, but and it was discussed how we can keep up to date with getting those resolved.
Okay, thank you, Tim. Any questions or perspectives to Tim? Okay, you please keep us briefed on all of that, particularly the sort of pathway issues you were talking about on neuro, Tim. We'll move on then to the Radiation Protection Committee. Paul Bonus, I've got as down as nothing to report on this. Anything you want to add?
No, the last meeting was postponed at the last minute, and I don't have the new date yet.
Okay.
So I'm sorry, I haven't got anything for you.
That's okay, Paul. We'll follow that up just to make sure the next meeting occurs as it should. Colleagues, happy to move on to the Safer Discharge group and Jean Arrowsmith. Jean?
Yes, the meetings are every 2 months, and the last one was only this week, so it's verbal, I'm afraid. There were lots of things raised, so I'll just try and do the headlines. One was syringe drivers, strangely, where if they go to the nursing homes, and we've only got a bank of 34, they never come back. And the nurses are hoping to develop they are developing a form, but actually it's got no legal standing. So we're going to take it to the ICB to find out what suggestions they've got, and presumably to get some more funding, because it's really important that we have got them available. The nursing staff and others all return them. It's just some nursing homes are more likely to do that than others, and they deny that they've even got them. So the fact that they're going to sign off, we're going to form, they'll sign, it has no legal bearing. Other things are criteria-led discharge. That's going really well on the wards where it's going really well, which isn't all the wards, but where it does, it really is useful. One of the reasons that that type of scheme and other things like that don't always go well is because of the doctors, consultants and ward doctors. They don't always believe in it and see it as necessary when they're so busy. And in some cases, they really don't believe in it, and the nurses are continuing to do work of that nature. The medicines to patients with the blood bikers, they've changed their hours to 6 p.m, 7 o'clock till 6 p.m. They were doing it later. They're still having issues where they go to the house and there's nobody in, but much less than when they first started to work. Some nurses, and we think they're probably agency, but I'm not sure, where you're supposed to ring a certain number to sort things out. They don't always ring the right number and it doesn't go to the right place, but that's being sorted. A lot of work going into safer discharge. The other thing is Simara and Anne can't always attend, and Simara's attendance have been a problem for quite a long time. So we are looking to changing not necessarily the day. We're hoping that it still be Wednesday every 2 months, but we're hoping to pick it up in the afternoon because they've both got meetings at the same time. So we see no reason why we can't just change it, and then they need to attend, because a lot of the issues, for instance, the team in pharmacy, we they investigated some complaints, some issues where there were problems, and they found that 3 of them were to do with pharmacy technicians. So there is quite a bit of work. I won't get into any detail, quite a bit of work that we need to do with Simara, because TTOs are still a problem in some instances.
Jane, that's very comprehensive. Thank you, and thank you for your work on this. It's probably worth just mentioning on safer discharge, but also the costs of medically fit for discharge patients stuck in the acute. The NHSE did an analysis which was released last month, which showed that the cost of medically fit for discharge, the net cost in Coventry and Warwickshire, was £48 million a year, which is an enormous number. And so the opportunity is enormous across Coventry and Warwickshire, not just on safer discharge, but speedier discharge. Members of the public will be pleased to learn that Swift, however, was in the top 5 of acutes in the whole of the country in terms of its medically fit for discharge management processes. Questions or perspectives to
Can I just say, I forgot to say that frailty patients, the nurses are ringing them the day after their discharge to check they actually understand their TTOs and they know what to take, etc. So that's a really, to say they're working hard would be to put it mildly. They're really trying to make it all correct, which, you can never do it 100%.
Super. Thank you, Jean. Questions or perspectives to Jean? Callie?
Yes, thanks, Jane. That was very insightful. All I wanted to ask is, do they collect any stats regarding the percentage of patients that are medically fit when they're discharged? Are there any stats say that many were medically fit, but some of them were not? Or
no, we would never. Sorry, just for clarity, Callie. We would never discharge someone who wasn't medically fit. So that scenario, would be a significant issue. The issue is that we have too many, even at Swift. Like I said, it's amongst the top 5 in the whole of the country, but we will still quite often have 30 patients who are medically fit for discharge every day.
Okay.
And the issue there is social care processes and the processes for getting people home. We can improve our processes a bit, but the main problem relates to social care. Ellie, would you agree with what I've just said?
Yes, I would. I think so. So people who are medically fit or medical episode completes the other way of putting it, for example, because they might actually be at end of life, but they've got a preferred place to care and we have a plan. So it's everybody that does not need to be here comes under that banner. And it is often the delays are stuff that the wards can't do anything about, such as waiting for a package of care or waiting for a specific care home bed. So that often causes delays. And then we do have that slight challenge with people that are from different areas other than Warwickshire, and therefore have different social services we have to liaise with. So that's another issue.
And just one
okay, I just wonder if anyone sleeps the net, that's all. But if you're quite confident, that's fine. That's okay.
I think it's really important because we've got members of the public on the line. But Ellie, correct me if I'm wrong. You know, the notion of someone getting through the net of being medically unfit for discharge would effectively be a serious incident, wouldn't it? Ellie?
It would. We would know about it. It would come back as an incident or a complaint for certain.
We had no formal complaints last month and the month before, even though there were some issues. But just to say about end of life patients, there is a risk where they smoke. And you're not really going to tell somebody at end of life you've not got to stop smoking. And there is a risk with the mattresses that they use could, ignite if there was a rip or something. So the nurses are working really hard to make them aware of that, but also developing a form that will mean that they have taken that choice and they know what the risks are. So it's important that they are. It's in writing that we know they know. Thank you.
No, thank you, Jean, and thank you for your hard work. Just a little conscious of the time, team. So
I was trying to be quick.
No, it's great, Jean. It was a good, great summary. On to the Salix project board. Michael Cox, over to you.
Okay, thank you. I'd like to say I take what I've written as read, please. The only thing I'd like to add to that is I've picked up some messages and such like we need probably some more metrics around what things are and what is actually being done, and I will try and endeavour to get quite a lot of that together tomorrow when the next project board is on for presentation next time, and I do believe there are some metrics starting to be published of the savings in terms of photovoltaic solar panels and the ground source pumps and such like, because it is quite a technical thing that everybody's doing. So if that's acceptable.
No, that would be great, Michael, if you can, just to bring it, into something we can all digest a little bit easier. That would be super. Thank you. Any questions or perspectives to Michael on what he's presented? Okay, thank you. We'll move on then to the wayfinding strategy group, and Michael, I'm back with you.
Yes, you are. Again, that group does meet regularly. We have got lots of the wayfinding screens, as Adam has reported in other places about the site, Warwick, which is about 8, so they are working. There are a couple of concerns about access, one being access to the public to the Wi-Fi and being thrown off, and the other one is about access to people to be able to use the technology because they don't have smartphones and such like, and then the tension then about having printed versions around, which is going to be something which is fairly challenging to manage. Otherwise we will end up with future state of lots of versions of the truth, which we're trying to avoid. But some of those issues are being taken up with IT services about bandwidth access.
Yeah, no, I agree, Michael. Certainly when I've tried to use the system coming into the new reception area, the Wi-Fi is an issue. The other thing which I find an issue is when you press on the sort of keyboard on the touch screen
No, I'll take the report and the minutes as read, Russell. I suppose for the benefit of the members of the public, this is the committee that sets out the business for the year for the Council of Governors, and in particular does things like choose the assurance items that we get put into the public domain, so hence the ERP today and the one that was mentioned about palliative care and end of life at the annual meeting. So that's what we do in this committee.
Super, thank you, Mike. Any questions to Mike on the GBC minutes and meeting report? Mike Flaxman?
It's a broader question, not just for Mike. In the actions in progress at the end for the meeting, we talk about the draft engagement strategy, the patient and public engagement strategy, which has gone missing and has disappeared for the last 2 years. Can you give us some assurance that we will eventually, as governors, see a draft of a strategy for patient and public engagement?
No, a fair challenge, Mike. Adam, could you know, I've spoken about this, but Adam, over to you.
Yeah, thank you, Mike. And it's a fair point. It is an important piece of work. And just to reassure governors and members of the public, we do have a lot of public and patient engagement work going on, many items of which we've heard about today. We have started work on this, but clearly the context we're operating in has changed significantly in the last year. We heard 6 months ago or so that Healthwatch obviously was being abolished, and Healthwatch is a major part of our previous public and patient engagement strategy. So we've needed to rebuild and relook around that. We're also entering an era of IHOs, and clearly the Trust has an aspiration to be an IHO. So I think where we would have previously done public and patient engagement more specifically on our services, we need to look more broadly at pathways of care and perhaps be leading some of that public and patient engagement work on a broader footprint than we would have previously. And so that is built in to our planning work. We will have a patient and public engagement strategy, and we will have something to share by the end of this financial year, but the context around us is changing considerably, as I say, and we need to build that in.
I just would have thought it was a box that needed ticking for you to be nominated as an advanced foundation trust so that you can move forward to other things. The 8 nominees that have been announced today aren't actually named to become advanced foundation trusts because they've got to be assessed by an independent panel before that occurs. So there's still quite some hoops to get through in terms of the process of becoming an advanced foundation trust. Whatever that means, I've no idea, because I thought it was a new foundation trust before, but now, according to the circular, it's an advanced foundation trust.
Yes, it's just become advanced. And I mean, I think we've got a strong narrative on our patient and public engagement work, not least because of the work of our governors. And so we will respond with that. I'm really keen we don't do something as a tick box. I'm really keen that we do something that is meaningful for our populations in Warwickshire. So that is what we're doing. But I think your point is very valid, Mike. We do need to have a strategy.
Perhaps before Healthwatch disappears, you could ask Healthwatch to help you to write it.
Indeed, yes.
Thank you for that discourse, gentlemen. And just on the Healthwatch point, I'd again just like to re-emphasise my immense disappointment on the fact that Healthwatch is being disbanded. I've always found the insights and work of Healthwatch to be extremely helpful to all healthcare trusts across Coventry and Warwickshire. And I think Chris Bain and other colleagues have done a phenomenal job on behalf of our population, and I send my thanks to them. The Patient Care Committee approved minutes of August and the meeting report from October. Jean, is there anything you'd like to add?
No, I'll take it as read.
Okay, thank you, Jean. Any questions on the Patient Care Committee reports? Okay, I can't see any hands raised, so we'll move on then to the report on resignations and appointments of governors. Sarah?
Thank you, Russell. I think the report's self-explanatory. It confirms that we've had no resignations or appointments made since the last report to Council of Governors in September. So happy to take any questions. Thank you.
Super. Thank you, Sarah. Then I'll move on if there are no questions, which there shouldn't be on that. On the annual self-assessment to the Council of Governors for which has recently been done, all 54 pages of it. Sarah, I assume we take this as read, but anything you'd particularly like to pull out?
I think just to thank the governors for completing it, because obviously we've had a number of new governors this time and the response rate did remain the same as last year's. Appendix 2 of the report is a comparison of the responses received for 2023, 24 and 25, which I think is a good overview. Just to note that the report has been considered by the General Purposes Committee, and they were concerned with the responses received under the membership and engagement section, which was reflective of the lack of engagement with the members within the constituency areas. So that it's here for the Council of Governors consideration and whether there's any actions that we need to take forward. Thank you.
Okay, super. I mean, the whole issue of member engagement has been a challenge all the time. I've been a chair at Swift, and indeed previously when I was a chair of Foundation Trust at the Robert Jones. But any questions or perspectives or thoughts on the self-assessment, colleagues? I think the point that Mike made just momentarily ago on the public engagement goes to the heart of the membership engagement issue as well. So we will pick up both of those going forwards. Colleagues, happy to move on? Okay, thank you. So we're then on to the Council of Governors and committee calendar of meetings for next year. The years fly by, guys. The years fly by. Sarah, thank you for all the work which you, Verity and Sue put into pulling this together. Any questions from colleagues? If you're not happy to approve them, could I ask you to raise a digital hand for me, please? Okay, duly approved. Thank you. And then we're on to the Lead Governor Annual Report for last year. Mike, we'll obviously take this as read, but anything you'd like to pull out?
Yeah, there are a couple of challenges I was going to pull out. One I won't because it was engagement. Excuse me. But the other one is the cancer and stroke services, which continue not to perform to the required levels. This poor performance is driven by partner organisation, which the Trust and the ICB, as Adam said earlier, seem to struggle to influence, which is disappointing for everyone, really. So a couple of important thank yous, though, to all the governors. I'll just remind the public that we are actually volunteers, so you've seen how busy we all are. And they continue to have a really positive input into the operation of the Trust. And particularly shout out to the new governors who've hit the ground running and have really got stuck in and made a difference. And echoing what you've just said, Russell, big thanks to Verity, Sue and Sarah, who support everything we do and a lot of the time keep us out of trouble. Their efforts are very much appreciated by all the governors.
Thank you very much, Mike. Any questions to Mike on the Lead Governor Annual Report? Now, Mike enjoys being Lead Governor so much, bless him, he put his hand up again when the recent election cycle was run and was the only candidate. So, Mike, it's a bit like one of those sort of carry on soldiering type of situations where everyone takes a step back when a volunteer is asked for and only one person is left standing. So Mike, on behalf of the whole council, I can't thank you enough for volunteering and continuing the work you do. So Sarah, we just need to formally note, don't we, the appointment of the lead governor. So if you're not happy to approve the appointment of Mike as the lead governor, can you please raise a digital hand? I'm blessed enough to have two lead governors, ex-lead governors on the call today, Michael Coker and Mary Malloy, and they both know that it's not the easiest of tasks on occasion, but you're doing a great job, as they did. I think we're on to any other business, therefore, colleagues. Any other business? Could you raise a digital hand for me, please? Okay, I can't see any hands raised. Are there any questions from governors that haven't been asked during the course of the meeting so far? Again, I can't see a digital hand raised. Are there any questions from members of the public who are with us today? If you can come off mute or raise a digital hand for me, that would be helpful. I've got a B. Barton. Apologies, I don't know your first name.
Hi there. Yeah, it's Becky Barton.
Hi,
I'll
Becky.
just put the camera on for you. I just would like to say this is my first meeting, so thank you for the invites that you've put up around the hospital to invite the public to this meeting. It's nice to be able to get involved. I would just like to say, is there any possibility that you could somehow make some information available to just give us a bit of an overview about what this what the committee is, what the governors do, and what this meeting's about, just so that we can be a little bit better prepared for future meetings. Obviously you guys know what's going on, but being new to it, it'd be nice to just have a bit of an introduction to understand a bit more about it.
Becky, I think there's some things on the website in that regard, but if I can ask one of my colleagues to just reach out to you, if you maybe if you're happy to either reach out to Sarah or a colleague with your your email address rather than pop it on the chat box now, and then we'll try and join things up. But I know there are things on the website, but thank you. Any other questions from members of the public? Okay, well then I'll bring this meeting to a close. We are just confirming the next meeting, which I think we're hoping to make at February the 26th. Is that the date which is correct, Sarah?
That's right, Russell.
Okay, so the next meeting will be February the 26th next year. You'll be pleased to know that will be my last chairing of the meeting, and by then we'll know who the new lucky chair is. So I suggest we adjourn now for some confidential matters, have a 5-minute comfort break, and get back together again at 3:30 to start the confidential meeting and try and free up some time for everyone. Thank you very much. Take care. Governor colleagues, see you in a few moments.